Times in your lifetime you get a really amazing person. And I met and actually helped recruit Dr. Bobby Eghbalieh about 5 years ago to Providence Holy Cross. It's actually been 5 years, Bobby. And, Bobby and I used to have long conversations, and he talked about his passion and his commitment. And I was thinking, he's too good to be true. So doing some background checks, I called the Da Vinci Robot company and asked about Dr. Eghbalieh, and they said he is like one of the best and busiest surgeons in not just California, but the country. And as we got talking, I had one small problem, though. I had difficulty pronouncing his last name. And he could see my frustration, and he said, Doug, it's very simple. It's like you take an egg, you take a ball, and then you say, yay. And that's my name, Eghbalieh. And I couldn't tell when he said that if he was like a surgeon or a cheerleader. And you know what? He's both. Bobby's an excellent surgeon, and he's a cheerleader for his patients, his support groups, and the underserved. And Bobby's kind of shy about this, but he's done many mission trips abroad to treat the underprivileged. So I'm very pleased and honored to be able to introduce Dr. You ready for this? Eghbalieh. Yay! Here you go, Bobby.
Can everyone hear me okay? Can you hear me okay?
Yes, sir. Yes, sir. Oh, there we go.
You see the
and you're wearing your purple.
Yes, there we go. Just wanted to make sure that the slides are showing okay. Yes?
They look good.
Okay, here we go. Thank you, Doug, so much for a wonderful welcome. I do recall, I cannot believe it's been 5 years already. When you and I spoke on the phone back in in 2016. Today, I have the pleasure of discussing the development and the progress and growth of our hepatobiliary, pancreatic, as well as complex oncology and robotic program. Please let me know if you have any questions during the talk, and I will be happy to answer them. So with that, our objectives today are to look at what our mission statement is. It's basically what Doug and I spoke about back in 2016. I also have to give a special shout out to Dr. Bernie Klein, who was a tremendous supporter of developing this program. Of course, I wouldn't be here without my brothers who, on a daily basis, after talking to Doug, would contact me to make sure that I didn't change my mind and I would come straight to Los Angeles. So thanks to them. I will review some of the cancer facts and figures, and I think this is essential to really understanding what we're faced with in the coming years and what we've been going through. Look at our own program history and development. Look at our current state of our program, not only for the hepatobiliary as well as pancreatic cancer program, but also the GI complex GI, our robotic program, our wonderful colleagues in our GI suites who perform some of the most advanced endoscopic interventions. And then, of course, no program such as a hepatobiliary or a complex GI program would be successful without other subspecialties, and specifically interventional radiology as our backup, and of course on the very complex cases, vascular surgery as well. And then I'll talk about what we're doing currently at Holy Cross. So our mission was to create a state-of-the-art hepatobiliary program and complex GI at Holy Cross. And my goal back then was to truly pursue a center of excellence and a tertiary referral center whereby all of the patients in the San Fernando Valley, whereby in the past would have to travel hours to go to one of the academic, either local or distant academic centers to get the same kind of care, would be able to come right here in their own backyard and essentially experience the same high level of care for their illnesses. And of course, not only to be able to deliver it, but deliver it in such a multidisciplinary patient-centered way, making sure that we have the most advanced technologies available for our patients, as well as improving not only their quality of life and outcomes, but more importantly, from a system-based standpoint, also reducing costs and length of stay. In the US, about 38.4% of men and women will be diagnosed with cancer. This is based on the data that was presented and reviewed from 2013 and 2015. Essentially, this year, we're projecting that 1.8 million people will be diagnosed with cancer. Of those, about 606,000 people will succumb to their cancer in this year. And if you think about that on a day-to-day basis, now we've been talking about COVID numbers every day, That's 1,660 deaths every day secondary to cancer. Wrap your minds around that number. It's a pretty big number. Now, California, just secondary to our population and the mix of the population, we generally see about 10% of whatever happens nationally. So we're expected to see about 172,000 cancers this year, and of those, roughly 60,000 people will succumb to their cancer. Let's look at our San Fernando Valley, Santa Clarita, and I will tell you that when you look at nationally, it's important to really put things in perspective. Obviously, we divide most cancers on a gender basis, male versus female. We have our incidence on the top and the death expected based on those. And generally, when we look at the cancers in regards to the program that we're developing, pancreatic cancer is the number in the top 10 for men and number 9 for women. But when you look at the mortality associated with pancreatic cancer, for men, it's number 3 essentially, 4, and also liver and other bile duct tumors are also up there. And for women, it's also very, very close. When we look at all cancers in lung, pancreatic cancer, as I said, is the 10th leading cause of cancer, and this year it's projected to be the 3rd leading cause of cancer. And if you look at the chart in front of you, you will notice that, of course, prostate and breast cancer for men and women are up there, but the number 1 cause of death from cancer is lung cancer, number 2 is colorectal, and currently number 3 is pancreatic cancer, and number 5 and 6 essentially are liver cancers. But if you also look at the last column, you can see that the mortality is significantly high compared to all the other cancers. We have been very successful at essentially not curing, but having a good grasp on how to go ahead about taking care of these patients with breast cancer, lung and colorectal, and even prostate, and overall survival rate has been improved. The sad part is that even with everything that we're doing, pancreatic cancer is still leading to become the 2nd most common cause of cancer-related death in about 5 years. And liver cancers, where currently are slightly lower, are going to move up to 4 and 6 for men and women in regards to the causes of death as an underlying diagnosis of cancer. This is a chart that has caused me nightmares for years. And for those of you who wonder why I wear a lot of purple, it's because of this one unfortunate line. You can see that pancreatic cancer has been increasing not only this last couple of decades, but consistently, whereby our improvement in quality of life and treatment plans for lung cancer, colorectal, breast, and prostate have come the other way and are coming down. And that's great. And why? What's going on? This is the data for California. This should be an eye-opening chart for most of us. I've been personally following the data in California since 2011. Back in 2011, we had about 3,700 folks with cancer. In just about 10 years, we've essentially doubled that number, which is a significant number. Now, we have, compared to the national data, our mortality was high. 94% of these patients back in 2011 died. Now, we're better at 80%, but we're not significantly better when you look at it compared to other cancers that we're treating. Now, when we look at the San Fernando Valley and where we are located, as I said, California sees about 10% of national cancers. But the San Fernando Valley and where we're located is roughly going to see about 25 to 30% of those cancers, just secondary to the volume and the population that we have in this area. Now, moving ahead and talking about another area is the non-alcoholic fatty liver. Very familiar with cirrhosis. Traditionally, liver damage secondary to alcohol, hepatitis B, and hepatitis C is very well known. Over the years, we've become very good at improving our care for hepatitis B and hepatitis C in regards to causation for cirrhosis. But unfortunately, given the epidemic of obesity nationally, the non-alcoholic fatty liver disease, which thereby leads to non-alcoholic steatohepatitis, otherwise known as NASH, eventually will lead into cirrhosis and eventually into cancer of the liver. And this is a huge problem that we're going to see, and it's not going away. Currently, about 64 million people are estimated in the US to have non-alcoholic fatty liver disease. Now, think about that. We know that 1 in 3 Americans is overweight, and of those, essentially 1 in 3 has fatty liver disease or NASH. That is a huge number, and specifically when you look at it, for example, as causation for liver transplantation, whereby we've had other reasons, NASH, non-alcoholic steatohepatitis, is the #1 reason for women currently to get transplantation in the US. And it remains the 2nd most common etiology in general for patients receiving liver transplant, surpassing what we traditionally had for cirrhosis, hepatitis B and hepatitis C, and other ailments that would allow us to perform a transplant. Keep in mind that we do not have enough livers in the country. So, number one, a huge growing problem, and number two, not enough livers to treat this population. So this is going to be another epidemic, essentially, that we will be facing in the coming decades. Now, as I said, when you have a healthy liver, God, I hope to God my liver looks as beautiful as the one on the left. I hope so, but I don't know. As you can see, with obesity, the progression to non-alcoholic fatty liver disease is there, but if early intervention and surveillance is pursued, it is potentially reversible to some extent. And so is maybe if when you get to NASH. But once you get to NASH, this is a one-way street straight to cirrhosis. And I can tell you in the last 3 years, I've sent 3 patients from Holy Cross during surgery identifying, oh my God, these people need a transplant, and transfer them to our academic colleague institutions in the area as well. But the sad part is that by 2030, in roughly about 10 years, 21% increase, up to 100 million people will have fatty liver disease, and about 63%, 27 million will have NASH. You could only almost imagine the gravity of what this will do to our medical treatments and our current facilities. Now, NASH obviously has risk factors, as I said, diet, obesity, diabetes type 2, obstructive sleep apnea, and of course, as with everything, there are some genetic factors. Keep in mind that with cancers as well as this, genetic factors play less than a 10% chance for most patients. Now, long-term outcomes, liver is by far the most important organ. I can keep a patient alive without a brain. I can keep him alive without lungs, without kidneys, without a heart. Without a pancreas, I can even keep a patient alive. I cannot keep a patient alive without a liver. The liver is one of the most important organs in the body, and because of its interrelationship with other organs, it leads to chronic kidney disease, cardiovascular disease, colorectal even cancers secondary to this, osteoporosis, osteopenia, cirrhosis, and of course, the end game for NASH is hepatocellular carcinoma, otherwise known as liver cancer. Here's another wonderful chart to look at it. HCC is hepatocellular carcinoma, and again, NASH. You can see that NASH is one of the higher risk factors, of course, advanced fibrosis, cirrhosis, older age, diabetes, male gender, alcohol, and of course, obesity. Liver cancer in and of itself has been increasing, and actually, since 1980, in just about 40 years, its incidence has tripled. Between 2005 and 2014, looking at the data, it has been increasing by 3% per year. There are treatment options. Obviously, if we catch the cancer early, surgery for resection is by far the best one. But unfortunately, as you know, we don't always catch them early. Thankfully, though, for liver, there's, we have history. As all of you may know, that Zeus punished Titan Prometheus by having an eagle feed on his liver. And we learned just from Greek mythology years ago that we can go after the liver, and if we cut the liver, based on what we learned in Greek mythology, the liver did regenerate overnight. And this was an important part. We don't really have another organ that regenerates. So we know that in the right patient, if we can catch them and they have enough normal liver left, if we resect the cancer, the remnant liver will regrow, as we learned from mythology. And of course, liver surgeons are fascinated by this. But having said that, there are multitude of other interventions that we can offer for the patients with liver cancer. Of course, best and foremost is surgical resection, which can be offered in a open, robotic, or laparoscopic approach, liver transplantation, radiofrequency ablation, essentially using heat to destroy the tumor cells, microwave, similar to what we use in the kitchen, a microwave ablation, which can also be done in an open fashion during surgery, during minimally invasive or laparoscopic surgery, as well as in radiology suite by our colleagues in the Interventional Radiology, going through a small little hole in the skin and performing this procedure. Transarterial chemoembolization, this is when we selectively identify the artery that leads into the tumor and destroy the tumor. Radioembolization, again, directed radiation therapy to those, which I will talk about a little bit later, systemic chemotherapy, which we're all familiar with, and of course, a whole slew of other approaches that are available to us for liver cancer treatment. So there's also the ability to be able to surveil for these patients. Of course, when we identify these patients, and we currently do have a NASH surveillance program currently at Holy Cross. We haven't expanded it to the region, but definitely it is started with our office to surveil patients that we identify very early and every 6 months, so we can essentially catch them at an early phase of the cancer. How do we come about collaborating and creating our current program? As you can understand, this is a very complex problem. These patients are very sick and they have a multitude of problems, and it's not a simple thing. And this could not be done without surgery, general and vascular, cancer surgery, gastroenterology, interventional radiology, radiology, pathology, genetics, pain service support. This takes a lot of effort to put this program together. So Doug and I, as you know, Doug and I had thousands of moments of questions back and forth and meetings, and really, you know, we looked at it for about a year. Are we ready to do this? Who do we need to talk to? How do we develop a plan for growth? Where do we invest? And how can we guarantee that we can continue to grow and improve? Is there a way that we can try to create contracts with special insurances for their hospital? And how do we aim for dramatic improvements, not just a little bit? And do we actually have the infrastructure? So we looked at our internal readiness here at Holy Cross. We looked at our performances. We looked at and projected our service demands. What was our in and out migration? I can tell you, this was a piece. We had many people literally digging in our backyard, if you will, and these poor patients were going all over the place. So we had a significant out migration within our system and the region because of the lack of directed referrals. So we looked, what were the physician referral patterns? Do we truly understand if the patients know what's going on? Do they understand what their needs and requirements are? Who are our competitors essentially, and what does Holy Cross have as a strength and a weakness, and how do we impact investments that will help us jumpstart the program? So, of course, we met with multitude of leaders, myself and many others. I can tell you that in this COVID era, I am on a morning call at 7 a.m. roughly every day of the week. But essentially, we have hepatobiliary focus groups. This is a group that meets in the entire west coast of all the Providence hospital. We have Digestive Health Institute, our Oncology Advisory Council, the Foregut Clinical Focus Group, the Integrated Network of Cancer Program, which is essentially a combination of Tarzana, Holy Cross, St. Joe's, St. John's, and Little Company Mary, combining their cancer programs to learn from each other to see how we can improve our overall programs, our own cancer committee and tumor board. We define our expectations in hospital and physicians, and we try to accurately and truly look at the data and see what we can do. And of course, we developed a plan. We wanted to become a tertiary referral center. We identified our gaps. We put a lot of instrumentation into bringing patients into our facility. We created the first pancreatic support group in the entire valley, one of only 3 in the whole Los Angeles area. We have a screening program for pancreatic cancer patients. There's only 2 in Los Angeles. We have one, myself and Dr. Ora Gordon, have started this program by a grant that was given to us by the Riley Foundation, $500,000 grant. We also have pancreatic cyst clinic. We try to identify and make sure patients are aware of us, having continuing medical education for the physicians, outreach, marketing. And then we looked at what we had internally. We got the XI robot. I know that Doug was talking about the robot that we have. We are one of few hospitals in the entire San Fernando Valley that have 2 XI, the most advanced robot programs in one hospital. Our genomic program, our Y90 program, which I will talk about through our interventional radiology, as well as ablation programs. We also partnered with the American College of Surgeons, the Pancreatic Cancer Action Network, who provides us a significant amount of support, as well as employee wellness. So we put all of this together, and I have to shout out again to Dr. Klein for giving me the green light. I can only imagine how many times he wanted to run the other way when I was walking towards him to ask a question. But I appreciate you, Dr. Klein, for really supporting us for this. And of course, we purchased, other things, and of course, we partnered. We definitely tried to recruit and collaborate with other physicians from City of Hope, FACE physicians, and other physicians to truly give us all the subspecialties that we need to really deliver the care within our own backyard. And, just like radiation oncology, we partnered with, City of Hope to ensure that these patients have one place to go, and so on and so forth. And of course, EPIC and our documentation has been a huge advantage, given the fact that we are able to essentially communicate with all the major academic centers locally. Okay. Furthermore, we talk to our nursing staff. We have oncology coffee chats. We educated nursing staff with a lecture series every 3 months or so. Currently, our expanded geographic market goes not only from the San Fernando Valley, but the greater Los Angeles, Antelope Valley, Palmdale, Lancaster, Santa Clarita, Bakersfield. I actually got a call from San Diego the other day. So I think people are recognizing that our program is growing. And of course, being part of the Holy Cross Foundation, I cannot ask for all of those wonderful people for philanthropy. We really depend on philanthropic investments and those folks who see what we have and could help us have the financial backing to continue to improve our program, and this has been a significant help as well. So once we created our infrastructure, we determined who's going to do what, how to communicate, and adopt a continuous quality improvement culture so that we just don't do the program just randomly. We can look at every case and know exactly what has been going on. So, they always say, if you don't know your history, you don't know where you're going. So what did we do truly in 2016 and prior? We were doing about less than 3 pancreatic surgeries a year. As a side note, a high volume pancreatic center does more than 10 to 15 a year, and some even would say over 20, which we'll talk about soon. We were essentially doing no liver surgeries. The liver-directed therapies were less than 10. There was no identified directed referral patterns. No one knew we existed, so patients were going all over the place. And of course, as I said, significant out-migration. Where are we now? So we started with that red circle, and I'm happy to tell you that we're now not only at the blue, and I think recently we've bypassed this blue circle in regards to the expansion of how and where we can reach and get our patients into our program. Currently, we have the highest volume center in San Fernando Valley for hepatobiliary and advanced GI oncology. We have trained HPB surgeons, oncologic surgeons, as well as the OR staff who's very familiar with what we're doing. We have the nursing staff on oncology floors who know how to take care of these patients. Keep in mind, these patients are some of the most complex patients, have high readmissions, have potential for high complications, and having a wonderful nursing staff as our backbone to truly ensure that post-operative care is delivered was key. Of course, we have navigators, and currently our multidisciplinary team has medical oncologists, GI doctors, diagnostic as well as interventional radiology, oncologic vascular surgeon. I can tell you that there are lots of these advanced cancers that would not have been possible for resectability had we not had, and I'm very lucky to have Dr. Sammy, who's my brother, who's a vascular surgeon, really being dedicated to helping me and helping us as a program truly attack these tumors and be able to give patients who would have otherwise not had a venue for these advanced cancers to have tumors resected. Pathology, our Dr. Yamashita and the team are amazing. Of course, Dr. Ora Gordon and her team for geneticists, pharmacies, our nutritional team. I mean, they have done a superb job as an inpatient to truly identify these patients early and make sure that they have the right nutrition. And of course, clinical trials and so on and so forth. So where are we today? Compared to 2016, we have had a significant increase year over year for hepatobiliary referrals as well as volume. Our surgical volumes are high. Our complexities have increased significantly. Our tumor board cases are ever more increasing on a week-to-week basis. And I will spend a little bit of time talking about the liver-directed therapies as well as the vascular resections that we're doing to truly offer this. And I have to say thanks to Dr. Klein and also Rex Hoffman. I met with them a couple of months ago now. And we actually looked at our data. Our 30-day readmission rates are the lowest compared to the others areas. Length of stay is low. Our complication rates are significantly lower than expected. I mean, it was amazing to look at these. I'm like, you guys are pulling my leg. There's no way our numbers are this low. And even our mortality numbers. So this has really, truly paid off essentially 4 years down the line. Our robotic surgery program, we were doing some surgery in urology and gynecology, but since May of 2017, we've had over a 560% increase in our overall cases. And I'll show you some of those numbers. And of course, we've had a significant increase in hepatobiliary and pancreatic robotic surgery, in addition to complex GI surgery such as hiatal hernias, esophageal, stomach, and colorectal. I love numbers. I think numbers are always important. And what I would like you to focus on is that nice arrow pointing upwards. It's amazing what we've done. If you look at back in 2016, we did 101 cases the entire year. We have not even finished 2020, but we're projected by end of December to reach 580 cases. That is roughly about a 30 to 40% year over year. And again, I want to thank the administration for getting us a second robot, seeing the demand, investing in the program that we have to truly allow us to offer our patients the highest and the best technology possible for minimally invasive and faster recovery and a better surgical intervention for these patients. When you look at our overall robotic and complex, again, from 2016, we were really not doing any of this. We were doing more liver resections, we're doing more gastrectomies, more pancreatic resections, more colorectal resections. I mean, the numbers are year over year increasing, and this is a testament to the support that we've had with the program from administration, as well as all of my colleagues, surgical, GI, and other departments who've really invested in this, and of course the management team at Holy Cross. I want to talk about what I've done. You know, I know Doug was kind of messing with me, but I really love offering patients as much robotic surgery. When I got here, I think in the first year we did about 46. This year I should be doing more than 220 cases, and I think we're going to do even more. So there is a lot of volume happening. And, you know, when you look at robotic surgery, it's always good to see what I call the rainbow effect. You don't want to see simple or one case or another case being done. You want to see a multitude of colors reflecting the complexity and the multiplicity of the different types of surgeries being offered. Our GI colleagues, Dr. Eghbalieh, Dr. Nagaraj, and others in the endoscopy suite are doing advanced interventions. Our referrals were increasing. I have to tell you, as you can see, I put a little sign for 2020 COVID. A lot of these procedures are on an elective basis, and unfortunately, the 6 months of COVID that we've been dealing with has essentially dropped our volume by about 25 to 30%. And that's a huge, huge drop, which I hope to God we will be able to, come back to. But what I can tell you is that over year, we were increasing our volumes because the referrals were increasing to our center to make sure that these patients get the level of care, and also for lower endoscopies as well. Lastly, our HPV program would not be what it is today without an integral interventional radiology program. I'm happy to work with my younger brother, Eghbalieh, and PIMG, who have been a big support for what we do here at Holy Cross. We've expanded the delivery, and I will go through what we can offer. And keep in mind that those tumors, and specifically liver tumors, if they are not resectable, IR and the minimally directed therapies are the best way to go and the only way to go for these advanced tumors. Of course, currently we're offering TACE. As I said, this is dedicated chemotherapy that's given into a tumor looking at the exact vessel that's feeding it. Y90 or yttrium-90 is also radiation therapy that's directed to the tumor. Cryoablation, this is freezing of the tumor, not only in the primary site, but also folks who have had pain from bony metastases, nerve blocks. As you know, pain during cancer could be a huge, huge detriment to quality of life. Microwave ablation and others. Now, where are we? You thought our robotic program was amazing. Look at the IR program. This is absolutely insanity. We are currently the #1 community program in the country, essentially, offering our patients radiation in a Y90 perspective outside of an academic center. And this is an absolute amazing achievement that we've had. We're currently the second in the country for BRTO, which is essentially ablating and modifying retrograde transvenous obliteration. Patients who have advanced varices of the stomach, we're the #1 place in the country that offers this at UCLA with Dr. Eghbalieh, and the #2 place in the country that offers BRTO is here at Holy Cross by Dr. Eghbalieh, who's my younger brother, who I'm very proud of. Of course, with Sammy, the two of them have been this huge support in helping me and helping us truly create this program. So as I said, our BRTO, we're #2 in the US. Y90, we're #1 in California. We're the third highest volume on the West Coast. City of Hope is #1 with 3 different physicians performing the same service line, and Sacred Heart in Spokane, Washington, and we're #3. So again, this would have been a service line that our patients would have had to travel outside of the region to really seek this care. As I said, we have a pancreatic cancer support group, which has been a very, very successful program. It meets on a monthly basis and currently on Zoom. Patients and families join this. We have support from the American Cancer Society. We have a dedicated dietitian. We have representatives to help us with nutrition. And thankfully, we've also partnered with industry to safeguard a grant that helps us continue this program. And of course, as I said, we also, and thanks again to Holy Cross, we have bi-weekly clinics for nutrition classes, as well as monthly classes and clinic, in addition to our inpatient education. Our pancreatic screening program that I talked about, we secured a $500,000 grant from the Susan E. Riley grant. This allows us to identify those folks who are at the highest risk for developing pancreatic cancer based on certain criteria. These patients are identified and are followed annually by genetics, myself, gastroenterology, as well as radiology. Of course, no program would be successful without fundraising. Holy Cross does have a team called Pancreatics. We came in 2 years in a row, 2018 and 2019, second in all of Los Angeles among over 110 different teams behind Cedars-Sinai every year in the highest group in regards to raising funds for pancreatic cancer as part of the PanCan Purple Cross. I do really love Purple, and I have to thank all the team members, all the hospital staff who have been champions in helping us really achieve this monumental goal of being one of the highest in LA raising money for pancreatic cancer. And with that, I will end there, and I will be happy to answer any questions. Thank you again. Thank you, Doug, for reaching out, and Dr. Klein, thank you again for allowing us to create such a wonderful program here at Holy Cross in San Fernando Valley. Thanks again, guys.